Thank you very much. Good afternoon, everybody. So thank you for having invited me here today to come and talk about the work that Alzheimer Europe has been conducting on the topic of sex, gender and sexuality in the context of dementia. And you can see here on this slide an image of the discussion paper that we produced last year together with experts of the working group. And so just here's the people in the working group. So it includes people with and without dementia, with different gender identities and sexual orientations, and of different ages and from different countries in Europe. And I'd like to add to that list Lucy Hadjikova and Martina Matlova from the Czech Republic, who work with Eva Holmerova, and because they were involved in the early discussions before we actually worked on the report. And the working group explored the literature on this topic, debated various issues, and with Helga and Phil obtained a series of testimonials from 3 lesbian women and 1 person identifying as non-binary. So we set out to look at how sex, gender and sexuality impact on the everyday lives of people with dementia, and to promote the right of every person with dementia, irrespective of their sex, gender identity and sexual orientation, to be treated with respect and have access to timely diagnosis, treatment and good quality care and support. And our target audience for this particular report was policymakers, health and social care students and service providers. And we're currently finalising a shorter report targeted at health and social care workers who are actually responsible for providing the on-hands care and support. And hopefully that should be finished by December, and any further inputs would be most welcome also from today. So the inevitable question. When a baby's born, one of the first things that people tend to ask, after checking whether the mother and the child are well, is whether it's a boy or a girl. And this label, which is recorded on birth certificates, follows most people for the rest of their lives. And it serves to some extent as a basis for how we're treated and for all kinds of assumptions about our interests, needs, capacities and wishes. And then as we make our way through life, our sex, gender identity and sexual orientation may further influence how we're perceived by other people, but also our self-perception and how we position ourselves within society and how we're positioned by society. So these attributes, in interaction with other factors, both at the level of the individual and also of society, they're not the sum total of who people are, but they do impact on people's lives considerably. And we looked at these factors in relation to people with dementia, as well as to their family, friends, and of course also including families of choice, in particular focusing on how they often come to the fore, attracting unnecessary or disproportionate attention, or on the contrary, are often ignored or disregarded when actually they should be recognised, valued and supported. As you can see here, this is the same slide as Eva had, but combining the male and female. There's a higher prevalence of dementia for women than men in every 5-year age group, and the most significant difference being in the over 90 age group. In 2018, there were approximately 2.8 million men and 6 million women with dementia in the 28 countries of the European Union. And whilst important, these figures don't actually capture the variety of gender identities and sexual orientations of those people and how this affects their experience of dementia. There are some estimations of the number of LGBTQ plus people in the general population, but estimates of how many have dementia are lacking. And it's a complex issue because, on the one hand, asking for such information, even with the best of intentions, could be considered as unethical, and even asking the question may make people feel uneasy and concerned about what people will make of how they will interpret the response. On the other hand, some associations welcome questions about gender identities, with opinions ranging from it being a token gesture, albeit in the right direction, to the belief that it will enable better support of LGBTQ plus people through greater awareness of their numbers. So this work that we conducted was in the context of our ongoing ethics work, and so we were therefore interested in issues surrounding principles such as respect for autonomy, so that's about people's right to decide about their own lives, beneficence, so here we were interested in the relevance of respect for dignity, personal integrity, individuality and personhood, also valuing relationships and social inclusion, and then also with regard to justice and equity and non-maleficence, we wanted to challenge stigma, disrespect and ridicule, to look at how to stamp out actual and anticipated discrimination, and tackling stereotyping, ageism, homophobia, and ableism. With regard to these issues and related concepts, it's important to look at various factors which directly or indirectly lead to inequity in the context of diagnosis for some groups of people because of their sex, gender, and sexuality. So the first example, living alone. People in the early stages of dementia often hide the difficulties they're experiencing from other people, or they're simply not noticeable to people they briefly encounter. But often, close relatives and friends notice subtle changes and encourage the person to consult a doctor. In most parts of Europe, more women get dementia and live alone compared to men. Lesbian and gay people are also more likely to live alone than heterosexual people, and older LGBTQ+ people often have less contact with their biological families, may experience social isolation, and are less likely to have children, all of which leaves them potentially disadvantaged with regard to getting a timely diagnosis. And then to make matters worse, some groups of people who have a higher risk of getting dementia actually have a lower chance of receiving a diagnosis. So older women, regardless of their gender identity or sexual orientation, often have lower levels of education, lower income, and less access to healthcare and to a pension in their own right. And these factors may interfere with seeking and obtaining a timely diagnosis. With regard to isolation, heterosexual men and women are more likely to have a network of relatives who are able and willing to support them, often consisting of daughters, daughters-in-law, nieces, and sisters. And older LGBTQ+ people tend to be more socially isolated and more dependent, therefore, on professional carers. And this has been linked to higher levels of depression, lower quality of life, mental and physical abuse in residential care settings, and a faster progression of dementia symptoms, which may in turn be a daunting prospect for people who have no one to turn to. I don't want to stereotype there, and I'm just basing this on some research, but not to say that every LGBT plus person is in this particular situation. So LGBTQ+ people don't all have the same experience, but some studies suggest that bisexual older adults in particular have lower levels of social support and sense of belonging to a community compared to lesbian and gay older people. And together with transgender people, they're also less likely to have supporting biological families. And Putney and colleagues suggest that whilst families of choice may provide valuable emotional support, LGBTQ+ people may have lower expectations of them in terms of providing long-term care. With regard to living in residential care facilities, there are twice as many women as men over the age of 65 living in residential care or care homes in Europe, where there's a tendency to underdiagnose dementia. Care home staff may sometimes suspect that a person has dementia, but all too often, no one makes sure that the person gets a proper diagnosis. And a diagnosis is important for people with dementia, provided that it's followed up by appropriate care, support and treatment, but also for the care homes, as knowing how many people have dementia also helps to upskill staff, create a suitable environment, and respond to people's needs and rights. Looking at the impact of perceptions of masculinity and gender-based assumptions on diagnosis, masculinity and femininity are socially constructed within different power hierarchies that have served historically to maintain men's dominance over women. And hegemonic masculinity is a term coined by Connell that describes a culturally idealized form of masculinity based on a set of values established by men in power over the centuries. And it's accompanied by social, often hidden pressures, expectations, and unspoken rules about the perfect expression of masculinity and stereotypes about supposedly normal or true masculinity. So help seeking, including checking out symptoms and screening, is perceived by some men as weak or feminine and in direct contradiction with the perceived ideal of the self-reliant, independent man and as breaching masculinity norms. However, when it comes to follow-up by doctors, a French ethnographic study revealed that men's concerns about cognition were taken more seriously and considered as more relevant and important by doctors, and that doctors had lower expectations for women who were more frequently diagnosed as having psychological or psychiatric problems, especially those who consulted early, and not offered a full differential diagnosis. It's also important to consider the intersection of gender and ethnicity. So Nielsen and colleagues found that only 23% of people diagnosed with dementia from minority ethnic groups in Denmark had received an acceptable diagnostic workup, and they found a significant underdiagnosis in the 60-plus age group, with only 1/7 of the general rate for men and 1/3 of the general rate for women from minority ethnic groups receiving a diagnosis. People from the LGBTQ+ community often experience discrimination and stigma, and homophobia is a term used to describe negative attitudes towards and discrimination against LGBTQ+ people, and transphobia used to describe negative attitudes and discrimination against transgender people. Many people in the older generations have experienced severe discrimination, such as being considered as having a mental disorder, being subjected to inhumane medical treatment, being estranged from their families, and not having the right to have children. The American Psychiatric Association considered homosexuality an illness until 1974, and homosexuality is still criminalized in over 70 countries. So discrimination and hostility are often openly expressed, but can be subtle and even unintentional. And although it may not be intentional, it's important to be aware that these assumptions and exclusions can be powerful and have a negative impact on LGBTQ+ people. So it's important to understand the challenges that LGBTQ+ people with dementia and their supporters face. And on this slide, you can see some of the examples of some of this discrimination and the challenges. I won't read those all out. And a few more examples I will read out. So broaching topics that would not normally be broached with non-LGBTQ+ people, so that could include talking openly about somebody's sexuality, making assumptions that exclude many or all LGBTQ+ people and that disregard their needs, ignoring the interests of LGBTQ+ people, so that could be with regard to their hobbies, TV programs in daycare centres and events, and also organising activities and services in accordance with assumed male-female needs and interests, focusing on traditional gender roles and undermining personhood. Some of the behaviour and attitudes described also apply to other people. So heteronormativity is a term that denotes taken for granted assumptions and expectations that promote a certain kind of heterosexuality that's linked to the nuclear family and to reproduction. People who find themselves outside of that framework, so that could be people who are not in a couple or who have no children, may also experience inconsideration or be considered and treated as other. So this could, for example, include unnecessarily referring to a woman as Miss, not just saying like Miss Gove, but Miss Gove, or organising events with an emphasis on the family and assuming that everybody has children. And this lack of sensitivity or intentional disregard for people's needs amounts to discrimination, and it can lead to shame, depression, isolation, and existential fear, thereby impacting on people's quality of life. This slide provides a brief explanation of some of the terms linked to the management of gender identity and sexual orientation. So coming out, being outed, and passing are key aspects of the management of gender and sexual identity for LGBTQ+ people, and they're linked to self-determination, well-being, privacy, and confidentiality, and often to stigma. Writing in the context of stigma a long time ago, Goffman pointed out that trans men are constantly scanning the landscape for fear of being inadvertently outed and thus, as he put it, alienated from the simpler world in which those around them apparently dwell. And this may also apply to other people within the LGBTQ+ community, especially for intersex people who, within the context of binary sex and gender identities, have no option other than to pass. So intersex people and some trans people who fully transitioned may need some degree of medical and physical support to manage their bodies and physical appearance. confusion and loss of inhibition may result in some people unintentionally disclosing their gender or sexual identities, either to the wrong people or in the wrong context, because it's not just a question of coming out one day or passing one day, it's in different contexts and situations, and of being uncertain about who does and who doesn't know. And this can lead to fears of outing themselves or being outed by health and social care professionals, and consequently to them becoming very much reliant on informal carers to prevent this from happening. So Neely, as you can see on this quote here, suggests that often the act of passing is complicated because it can be seen as a form of deception and may easily lead to violence. But paradoxically, from the perspective of trans men, it's often the opposite. And Neely describes passing in terms of authenticity, whereby passing means being read or seen for who you are, a man, and hence a potential source of pride. Nevertheless, it can be stressful to maintain over time, especially for people with dementia who are experiencing difficulties with memory, concentration, and planning. So we included, there are lots of recommendations in the report, which I would recommend that you consult online, but just in relation to this particular topic. So we recommend do not assume that all people with dementia are cisgender, which means they identify with a gender that matches the biological sex assigned to them at birth, or that they're heterosexual. Reflect on your own assumptions and language, and avoid inappropriate humour or banter based on appearance, dress or mannerisms, and challenge this when it occurs. Ensure that all people with dementia are free from violence, discrimination and harassment, regardless of their gender identities or sexual orientation, and try to create and communicate a feeling and atmosphere of safety and acceptance of everyone, regardless of sex, gender and sexuality. And be aware of different family structures and include friends, partners and chosen family in the care and support of people with dementia. So moving on to the right to a sexual life, close, meaningful relationships often provide a source of support, a sense of security and a sense of well-being and connectedness, impacting on quality of life expectancy and mental and physical health. And sexual relationships and acts can, in addition, be a source of satisfaction, support, reassurance, and a way for both people with dementia and their partners to cope, as well as a positive part of carers' lives and something familiar or a kind of safe harbour amongst all the changes. And sometimes sex is one of the few things that partners feel they can still share and enjoy together. However, dementia can impact on relationships and on couples' interests in sex and the satisfaction that they gain from it. People with dementia nevertheless have a right to the enjoyment of sexuality, which is considered as a fundamental human right and enshrined in several human rights frameworks. Unfortunately, ignorance and prejudice at the personal as well as the institutional level often serve to deny the basic human right of people with dementia to sexuality, as echoed in the statement that you can see on this slide. So some of the challenges are, though, that what we know about sexuality and dementia is largely based on self-reporting by carers other than people with dementia, many of whom who are female, and by people who are heterosexual or assumed to be heterosexual, and many of whom who are married. So as sexuality is still a fairly taboo subject, not everyone is willing to share information about it. And those who are willing and comfortable to talk about sexuality don't necessarily have the same or similar experiences to those who aren't, which is just a problem which we still need to tackle. And some groups of people are underrepresented in research about dementia and sexuality, so their perspectives are missing from the picture. And when the sexuality of people with dementia is addressed directly, it's often limited to the residential care context and framed as problematic. Looking at the impact of dementia on relationships, dementia is frequently described as affecting the quality of people's relationships, resulting in the loss of companionship, of a trusted friend and lover, of reciprocity, and of just someone to talk to and confide in. And it may also progressively affect relationships of power, dependence, independence, and interdependence. The extent to which couples are at ease with nudity, non-sexual bodily contact and privacy surrounding toileting varies considerably. And this can be exacerbated if the relationship is perceived as asymmetrical, with the person with dementia being perceived as childlike and the partner feeling that they've become like a parent. So sexual intimacy may then be perceived as somewhat incestuous and thus inappropriate or destabilizing. And partners sometimes find it strange and disconcerting to find that they are now considered as carers, at least by service providers. Although LGBTQ plus partners are sometimes not considered as carers when it would actually be helpful if they were. Also, the carer cared for distinction, or also including support, not just care, is not always clear within couples because the partner who does not have dementia may nevertheless need support and care for another condition. So it's not quite so black and white. Also, caring is often associated with women and femininity, and many women have had the main responsibility for the care of children and other dependent relatives at some point in their lives. And this could challenge some men's masculinity, although many men report satisfaction with being able to care for their partners as a testimony of their love for that person. And a few studies have reported that they are, however, more likely to get help with caring and not provide intimate care themselves. But then when we're talking about relationships, we often forget new relationships. So aside from assumptions that older people are asexual, it's often assumed that people with dementia, being normally older, are either single and happy to be so, or they're in a long-term stable relationship. But less attention is given to people with dementia who aren't in stable relationships, who are seeking either a new relationship or just a sexual partner. And anecdotal accounts have revealed the dilemma that some people face about whether to reveal straight away or in dating profiles that they have got dementia, or to wait until later once they've got to know somebody better. And the dilemma is linked to the desire to attract a partner, to be honest, whether to pass in that situation, and what the implications are in terms of trust, honesty and support within relationships. With regard to the problem and problematization or pathologization, I'm not sure if that's right, of dementia, sexuality touches on several issues such as the rights to sexuality, well-being, capacity to consent, impact on other people, and even criminal offences. But discussions about sexuality and dementia often focus on sex as a problem or abnormal. Terms such as inappropriate, improper, sexually ambiguous, hypersexual, and sexual dysfunction are often used. And sexuality is often seen as a challenge, inappropriate, or a medical issue to be controlled, especially in the case of men with dementia. The main focus is often on coping with the sexual demands of people with dementia and the sexual needs of their partners. That's often how it's phrased. Displays of affection or courtship towards other residents in care homes or towards carers may be interpreted as misplaced or inappropriately voiced expressions of a human need for intimacy. And it may also be the case that it's the place rather than the act that is inappropriate, and that if people with dementia had the privacy that they're entitled to, their sexuality would not become a matter of concern and public debate. The consequences of labelling the expression of sexuality as inappropriate can be considerable, resulting, for example, in loss of the right to sexuality and to family, the person having to move into residential care or to a specialised unit, and in some cases, even the loss of a loved person due to one of the partners being moved into a different facility. So if the people making decisions about what is appropriate are homophobic, sexual relationships between two men may be seen as inappropriate. If they believe that a person with dementia cannot consent to sex solely on the grounds of having a diagnosis of dementia, then sexual relations would always be deemed as inappropriate. Staff in residential care settings or hospitals often have to deal with relatives trying to impose their values and beliefs, to seek restrictions on the sexual life of the person with dementia, and to discuss the sexuality of the latter with them. They believe that they have an automatic right to do so, reflects to some extent the tendency to infantilise people with dementia, to treat them as children, and failure to respect their privacy and confidentiality of information about them. So some degree of discussion may sometimes be justified within the context of trying to understand the needs of the person with dementia. However, such information shouldn't be shared unnecessarily, and Hughes, Beattie and Shippen emphasise the fine line that there is between families needing to know what's going on and wanting to control what's going on under the guise of best interests. Whilst there's often a great emphasis on the capacity to consent to sexual relationships and acts in residential care settings, people are often deprived of their right to express their sexuality by informal restrictions, and these are not based on a legal or even administrative process to assess capacity, but on assumptions, paternalistic attitudes, ignorance, and a culture of oversight and institutional procedures. So to conclude, it's essential to challenge blatant or subtle discrimination, hostile attitudes and behaviour, and violence towards people based on their sex, gender and sexual orientation. We need to strive for greater sensitivity and a greater acceptance and appreciation of diversity, to give people with dementia of all gender identities and sexual orientations a voice, and to ensure that unequal and discriminatory power structures and societal inequalities are taken on board by policymakers, researchers, health and social care professionals and the general public, so as to develop more ethical, inclusive and a humane society for people of all gender identities and sexual orientations. And if you'd like to know any more about this work, just go onto the Alzheimer Europe.org website and you'll see it under resources. Thank you very much.